introduce our first speaker. Our first speaker is Ms. Lindsay Swart, who is a member of the Occupational Therapy Association of South Africa. She has a keen interest in the legal aspect of disability in the workplace and sat on the drafting team of the Employment Equity Act Code of Good Practice on the employment of persons with disability. She is also a regular speaker on the legal aspect of workplace disability management, occupational health and safety, occupational health and safety and ergonomics. She is frequently consulted by colleagues, employers, persons with disabilities, and occupational health professionals for advice on managing disability in the workplace. She has provided expert testimony at workplace disciplinary tribunals and at the CCMA. She was appointed as an external consultant to the Employee Wellness Dialogue Program in the President's Office in 2023, both the Johannesburg, Cape Town, and the Durban offices. I would like to please welcome Ms. Lindsay Swart.
Good evening. Thank you, Boitumela. I'm going to just share the screen. Can you see it?
Yes, we can. Thank you.
Excellent. Thank you so much, and good evening to everybody. It's really a privilege to be addressing you this evening. I am starting off with probably what is the boring, arguably the boring part of the talk, but we know that the laws underpin everything. So what I'm hoping to do in the next 20 minutes is just to give you an absolute bird's eye view of the legal principles that are important when looking at disability and incapacity in the workplace, and particularly with respect to people with mental health conditions. So I'm not going to go through all the laws. Most of our laws do address various aspects of this topic, like the Basic Conditions of Employment Act and Skills Development Act as well. But the principles are largely in those three laws there, the Occupational Health and Safety Act, Labour Relations Act, and the Employment Equity Act. So we will have a look at those. And then I'm going to just share with you how the occupational therapists look at reasonable accommodation. I think probably most people on this platform this evening are aware that mental health issues have really escalated in the workplace. This statistic from the South African Depression and Anxiety Group, it's a 2017 survey they did, they found that 72% of people surveyed admitted that mental health issues had affected their work performance at some point. That is a huge number. And what we do know is that this number has increased significantly since COVID. So mental health really needs to receive our attention, not only for the individuals who are affected, but employers are also really looking at this issue now. We see there are a lot of hidden and not so hidden costs of not mental health. I put some of them up there for you. Absenteeism costing companies a huge amount. I have a statistic from OHS, the Occupational Care South Africa. In 2022, absenteeism cost the South African economy between 12 and 16 billion rand. And if you think that's bad, the presenteeism, when people are at work, not engaged, not performing, they are often depressed and not performing properly at work. The statistic for presenteeism is a lot worse. I have a Stats SA statistic from 2019 where they estimated the annual statistic loss is 89 billion rand. So that is something that employers really need to look at. And then associated with that, we see reduced productivity, higher healthcare costs, medical aids and insurance. Employees, staff turnover, which is also a cost to the company, training new people, settling them in. Increased workplace conflict, that could be that in many mental health conditions, social skills may be impaired, with the result that people are more prone to interpersonal conflict. But what I've also seen personally is employees of the worker who has mental impairment are often expected to take on extra responsibilities because their colleague is not performing, and this eventually leads to problems as well. We see increased safety risks when people are not concentrating, when their minds are not on their jobs, particularly sensitive jobs. Accidents and all sorts of issues come up. And then all these things can lead to, if they blow up big enough, to reputational damage to the company and legal compliance for the employer. So we see that employers are starting to manage this better. We see better insurance benefits to try and get people back at work. But what I want to highlight now is that this has to be done against the backdrop of the legislation. And this is not always easy. Sometimes we think the legislation is very definite and we have strict guidelines. But what I would like you to just realize is that the law is always, and particularly labour legislation, is trying to strike a balance between rights and responsibilities and legal and ethical duties and obligations of, firstly, the employer, also the employees and other stakeholders. And so sometimes this can result in the whole situation being a little bit confusing when it comes to the law issues. And that's why we have court and legal precedents and case law. All right, so getting on now, we're going to just look quickly at the Occupational Health and Safety Act. Section 8, the principle that I want to highlight is the employer's duty to ensure a safe and healthy work environment. And this includes doing a risk analysis, identifying and eliminating or mitigating any hazards to the safety or health of the employees, and not permitting employees to partake in activities until there is decent control of these risks. Now, traditionally, the focus has been very much on physical conditions, but what I want to just also emphasize is the law is very global and broad, deliberately so. And what we are needing to do as healthcare professions is to start pulling in mental health. These laws can be interpreted for mental health, and we need to start allowing that to happen. There is already quite a bit of case law on mental health. I don't have time to go into that, but I would encourage you to actually look at that. So one of the regulations under the Occupational Health and Safety Act that does help us is the ergonomic regulation. In 2019, it came out. And while many of you might think ergonomics is very physical, it's about lifting things and good posture and all that, we see that ergonomics is much broader than that. There are 3 domains: the physical, the cognitive, and the organizational domains. And I just want to here highlight the cognitive domain, which deals with mental issues such as attention, perception, memory, reasoning, judgment, and so on, human error, motor response, and so on. And the risk factors that we look at when we are doing risk assessments are things like looking out for high mental workloads, lack of control, inadequate informational feedback that employees might be exposed to. Uncertainty in the workplace, inadequate training, social isolation is a big one, shift work's also a big problem, and irregular hours, and so on. There's a lot of these things, but when ergonomic risk assessments are done, then these need to be identified and picked up. And just again to emphasize that we can use this regulation with mental health risks. I'm giving you the definition of ergonomic risk from the regulation, and you will see there that it's a very global definition. A characteristic or action in the workplace or workplace conditions or a combination of these that may impair overall system performance and human well-being. And so we can bring in mental health issues and identify them under this regulation. So looking now, the next one is just our quick flash visit to the Labour Relations Act, and the section here deals with dismissal, and particularly dismissal due to incapacity, due to illness or injury. And what I want to highlight here is by incapacity, we mean the employee's inability to perform their work duties due to ill health or injury. This is what is called legally a no-fault dismissal. In other words, it's nothing that the employee has done. They're sick, they're injured, they have a condition. And typically in the Labour Relations Act, very often we're looking at temporary type conditions in the Labour Relations Act, where it turns into a long-term disability. Yes, dismissal is dealt with under the Labour Relations Act, but the minute we see the issue of disability, we also need to go and look at the Employment Equity Act, which we will look at quickly afterwards, after the Labour Relations Act. So what we're hoping for under this Labour Relations Act is that the employee can recover and return to duties. The employer is charged not to dismiss them the minute they become disabled, but to fully or incapacitated, but to fully investigate the incapacitation and, where possible, to try and accommodate them until they are well enough to resume all their duties. So what would this accommodation look like? Well, for mental health, here are some things that we occupational therapists certainly consider, and that could be temporary adjustment to duties, flexible work arrangements. It could mean coming in a bit later if the person has difficulties with traveling in peak hour or waking up early, sometimes working from home, which became a big thing in COVID. We might provide access to professional support, extra sick leave, and then graded return to work is a big one now amongst OTs. This is where we will get the person gradually back to work, perhaps start off with 50% of their duties and then increase that in a very systematic way until hopefully they are performing all their duties. Temporary redeployment to a different department or a different type of job. Mental awareness training for supervisors, colleagues. For that, we definitely need that to happen under a trained and qualified mental health care practitioner, because there are a lot of ethical and confidentiality and so on issues involved in that, but it can be very useful. And finally, case management, which OTs are increasingly doing, and the insurance companies are asking for more and more to get these people back to work. All right, so now moving on to what happens when a person doesn't get better and they are diagnosed, they have a permanent kind of disability. Then we need to pull up the Employment Equity Act. This act has two main provisions. It prohibits unfair discrimination, and that applies to all employers. It doesn't matter how small or big you are, and all employees. Nobody may be discriminated against on any grounds. All the grounds listed in the Constitution are included in that. The second provision is really for what they call designated employers. That's bigger employers as defined in the Act, and then for designated employees, and that is defined in the Act as there are three groups that are considered there, and that is Black people, women, and people with disabilities are considered as designated employees and therefore included in affirmative action. All right, so who would then be considered and qualify as a person with a disability? There's the definition. It was recently updated, and it is people who have a long-term or recurring physical, mental, intellectual, or sensory impairment, which interaction with various barriers may substantially limit their prospects of entry into or advancement in employment. And I'm going to highlight three conditions which are required for a person to be classified as disabled. You see there long-term or recurring, and the recurring is very useful in mental health conditions because sometimes we have people who have a diagnosis and they may have periods of complete wellness, but then sometimes typically a cyclical kind of experience of their condition, such as bipolar disorder or depression or whatever it may be. So they are included. We see there any mental condition is included, but then the third requirement is very important. These impairments must be substantially limiting, and often then employers are requiring a functional assessment of the person to determine whether there is substantial limitation. Just a note I want to bring in on that, and that is if you look at that definition, there's nothing there about diagnosis or medical impairment. It is not a medical definition at all. It is all about the person's ability to perform the work, and that is how we assess it. So once a person who has been declared disabled is allowed to get reasonable accommodation, and that is the definition of reasonable accommodation. It's a modification or adjustment to the job that will enable the person to perform and participate in the job. And just a note on that, accommodation doesn't mean employers must accommodate and include people who are subpar performers. What the accommodation must do, it must allow that person to perform the job properly. So we see that employees or job applicants can qualify under the Employment Equity Act for reasonable accommodation if they meet the definition of disability and they are qualified for that job. The employer has a responsibility then in reasonable accommodation, both a financial responsibility. So so long as the accommodation is for that job, then the employer needs to pay for it. They can't require that person now to buy a fancy computer software program to run on their computers. The employer would be expected to provide that, and they would be expected to take responsibility and be involved in the implementation. So reasonable accommodation needs to be seen as an ongoing thing. It's not a once-off thing. So employers need to be continually reviewing whether a person needs to be accommodated or whether the accommodations need to be reviewed. Sometimes the workplace changes or the person's condition may change, and then accommodations need to be reviewed. But just the note there that the employer is the one who decides whether the accommodation is reasonable. That is something that the courts will need the employer to make that decision. We can't go and wave our fingers there and say this is reasonable. Reasonable is reasonable in terms of the employer's setup and what they can afford and what is practical and reasonable for them. So the argument against reasonable accommodation is provided in the Employment Equity Act, and that's called unjustifiable hardship. And that just simply means that that an employer will not be expected to accommodate someone if it really causes undue hardship to them. But they will then have to, if it is challenged in a court of law, in the labour court or in the CCMA, they will need to prove that it is a hardship. So what I'm just going to run you through now is just the process that we occupational therapists typically use in accommodating someone. The first steps I like to do is just check that this is a person with a disability, that they are entitled to this reasonable accommodation. So the first thing I look at is there someone who has problems with the essential job functions? If so, are they suitably qualified for the job or under the law? And if so, then do they qualify as a person with a disability? Once we've got those boxes checked, then we can actually put them through a process which includes first doing a job analysis, a functional job analysis of the inherent job demands, and then doing an assessment of that person's functional abilities, workability specifically, in terms of those job demands. So if the job is demanding a high level of interpersonal contact and social skills, then we need to assess, does that person have those abilities? So with these two, once we have assessed the job demands and we've assessed our person, we compare these two assessments and we identify whether there are any gaps, whether the person is where they're not meeting the job requirements. And then we identify potential reasonable accommodations that could fill those gaps. And we always do that with a person with disability and the employer. This is not something that we OTs will do quietly and discreetly on our own. It is always a consultative process, and it often might include technical experts, for example, IT people or industrial engineers where necessary. We then select and implement the reasonable accommodation, and then we take it through a process where we will check it out and review it and make adjustments as necessary. So that in a nutshell is where we are. I just want to quickly have a word, because this often comes up. What about reasonable accommodation running into safety provisions? And what I just want to say there is, while the Employment Equity Act enshrines the right to reasonable accommodation and changes in the workplace for people with disabilities, this can never override safety. So the minute it breaches the Occupational Health and Safety Act, it is considered no longer reasonable, and therefore it won't pass that test of reasonable accommodation. The worker may never pose a safety threat to themselves or to an undue safety risk to themselves or to anybody else, either directly or indirectly. So that, in a nutshell, is the main legal provisions. Thank you.
We'll go for tonight, and it is Miss Misha Knight. She is a mental health occupational therapist at Groote Schuur Hospital, where she has initiated a staff mental wellness program. She has a special interest in the mental well-being of healthcare workers and in the pandemic, creating a pioneering role within her institution in leading a staff wellness program. She has designed a strategy to create hospitals that prioritizes well-being and fosters healthy, safe, collaborative, and responsive environments where the staff feel that they are seen, heard, and have a sense of belonging. She has also done additional training in group techniques, including experience groups, projective techniques, and psychodrama techniques. She is a licensed I-ACT instructor, which is accredited by the Royal College of Psychiatry in the UK. This allows her to train people on evidence-based tools and models for positive mental health and well-being in the workplace. She was a panelist at the COSASA and WHO World Patient Safety Day in 2020. She is also currently pursuing her master's in public mental health at the University of Cape Town. Thank you so much and welcome, Ms. Naik.
Good evening. Thank you for having me. I am going to share my screen. Are you able to see that?
Yes, we are. Thank you.
Okay, great. So thank you for having me this evening, and I'm going to be talking about psychological safety in the workplace. My name is Misha, and I'm from British Care Hospital. And today, the outline of the discussion is going to be on psychological safety in the workplace, mental health distress, as well as the workplace wellbeing program that we've initiated, and then return to work in terms of mental health. So I'd like to start off with looking at this picture. So to introduce the concept of psychological safety in the workplace, we have to look at our current occupational health and safety practices. If we look at physical injury at work, like a fall, for example, we instinctively know what to do. We are able to investigate and understand the due causes. We will assess the environment and rule out slippery surfaces, misaligned steps, or broken banisters. There are protocols to be followed by the individual, the organization, to both support the individual and the manager and protect the organization. But what if there's a physical or psychological injury on duty? Do we know how to recognize it? Do we know what a psychological injury entails? And what are the protocols in place to protect and support the employee, the organization, and the manager? And who is responsible for this? Is there something built into our current occupational health and safety preventative and promotive practices? So the answer to this is somewhat complicated. By what we understand by psychological safety, organizational culture, and workplace stresses. It is further complicated by the stigma and connotation that mental health in the workplace brings. Currently, physical injuries are take on a systematic approach. So we have the same for psychological injury? Currently, this takes more of an individual approach, and let me explain. When an individual breaks a bone from a fall, do we say that the bone is weak? Or do we recognize that the stresses were too much to cause the injury? Similarly, when an individual needs to take time off from work for anxiety, stress, or depression, the language we use is different. And we often say the person is not strong enough or not resilient enough. And our modus of operandi currently is go and get help, sort yourself out, and then come back to work. Do we check for the causes? Do we check what caused the injury? Do we understand what work-related factors contributed to the current state? And do we have protocols in place to assess for cause? And this gives us a start to understanding what psychological safety is. And this concept was first introduced by Amy Edmondson, a leading researcher in the field in organizational psychological safety. And she defines psychological safety as the belief that no one will be punished or humiliated with ideas, questions, concerns, or mistakes, and that the team is safe for interpersonal risk-taking. In other words, this means, can people speak up, offer new ideas, be yourself without fear of negative consequences, like being ignored, ridiculed, or punished? But what psychological safety in the workplace goes slightly beyond just feeling comfortable sharing ideas. It is also means that feeling like an equal team member and that your contributions are valued and heard without fear of judgment and discrimination based on race, gender, sexual orientation, or your background. But let's not get psychological safety confused with being soft or nice. It is not about holding back on giving constructive feedback or avoiding tough conversations. Instead, we must create safe, inclusive space for vulnerability where mistakes are seen as opportunities to learn and grow. And it is about creating a safe space where team members feel comfortable bringing their whole selves to work, speaking up and taking risks without fear. An environment where we can call out unacceptable behavior such as workplace bullying. So we now understand that looking at the psychological safety needs to take, rather than an individual approach, we need to take on a systematic approach. And not only affected by the individual's coping mechanisms, but also the organizational culture, work environment, and the workplace stresses, where we focus rather on mitigating and managing psychosocial risks in our occupational health and safety practices. So to understand this a little bit, we look at the 6 areas of workplace design that can impact work-related stress, as guided to us by the Health and Safety Environment Management Standards. So these are the 6 areas that we know that affects people's workplace stress. And workplace demands such as work patterns, workload, and work environment, such as a nurse working a 12-hour shift or a surgeon operating for 12 to 14 hours, has an impact on the workplace stress. How much control a person has in how they do their work every day, in how they communicate, collaborate, and are involved in decision-making, and their personal development opportunities also impact their workplace stresses. So how much control does a person have in terms of their rosters? And is there flexibility in terms of looking at a mother who has young children that need to be dropped off at nursery in the morning? Then we look at support. So what kind of support does the individual employee have? Regular, is it constructive? Do we have resources and training available to support their gaps in knowledge? How is the support in terms of line management and from their colleagues, and awareness and access to support systems outside of their departments? This is also where occupational therapists come in and involved, where we help with return to work post a long-term illness and reasonable accommodations to support their return. We also understand that relationships in the workplace impact your psychological safety, and positive work environments help people deal with conflict and call out unacceptable behavior such as bullying. Role clarity and clear sense of roles and responsibilities also impact a person's workplace stress. Are these clear, and are there no conflicting roles is often what we need to consider. And then lastly, change. And we saw this in COVID. How is change managed? Does the organization have access to informing everybody about change? Do they consider how this is communicated? And are people consulted with the consequences of the change? And do they have an input into the proposed changes before they're implemented? So all of these play a role in impacting the work-related stress. And we now can recognize that it's not an individual approach, but that the work organization as a whole also contributes to the stress that we feel. And one model that we use, as designed by the University of Sheffield, is the Igloo method. And the Igloo method looks at how do we support an individual who has to return to work following a mental ill health. And this is how it has functioned before. But I'm going to say let's look at it in a proactive way too. How do we support the individual and who's currently affected by workplace stresses, and look at it from a holistic point of view? So how do we train the individual, the leader, the group or the team, and the organization to manage mental health at work. And this is a really amazing resource that's available to teach us what can be done on each level. So why do we need to know this? And my fellow panelist has touched on this, and I'd like to continue that conversation because it is an important one. And that is, if we don't address the poor mental health at work, and it starts off as mental distress, but it can easily lead to mental ill health. And one thing we need to recognize that it doesn't only affect the organization, it affects the employee and service delivery. And in a hospital setting, which is my background, this is important. So as discussed earlier, productivity is one of the things we see that's impacted immediately. And that the global estimate at this point is $1 trillion annually that's been lost on productivity due to poor mental ill health. And then we have presenteeism, and I'm not going to repeat what my colleague said, but also absenteeism. Then we have high staff turnover, and we know that people want to work in organizations where they feel safe, where the environment is conducive to their progress and to bring out the best in themselves. And also, this is not going to only hire the best people, but we're going to retain them. And if we have a culture that doesn't support this, we will see a high staff turnover. Team dynamics is naturally impacted, and this was highlighted earlier with somebody that's not productive. It impacts the rest of the team that have to pick up on what is not able to be done. And then healthcare costs, and that was also discussed. In a hospital setting, patient safety is compromised, workplace safety, quality of patient care, and patient satisfaction. And then lastly, on an individual basis, we can see and we understand that individuals' overall well-being and is affected. Health behavior such as substance use, increase in unhealthy behavior such as eating or not eating because we are stressed or don't have time for it is seen. It impacts staff morale, productivity on an individual level, and then job satisfaction and relationships in the workplace. So on a global level, we need to understand that and recognize that the SADC says that 1 in 4 South Africans suffer from mental health disorders in the workplace. And 40% of this is related to anxiety, depression, and burnout. Globally, we know that by 2030, depression will be the single largest healthcare burden that we are going to be facing with. So the time is now for us to understand that this is something that we needed to start acting on now. So what I'd like to touch on is how we at British Care did so. So our journey started in 2019. And this was prior to the pandemic, where we recognized that there was a rise in 2 of our stats, which was a rise in the incapacity management application. So this is PILLA or long leave, that had a mental health component to why people were needing time off from work. And the numbers were increasing tremendously. We also recognized our employee health and wellness stats at the time, which was ICAS, sharing that the main 2 reasons our employees were accessing them was for stress in the workplace and relationship dynamics in the workplace. That was costing their mental health. Then we saw also a trend in the increase in the frequency of people accessing our employee health and wellness provider. So the hospital recognized that we needed to take a proactive approach to supporting and the mental well-being of our employees and move away from a reactive approach that is currently being used. So what we did was we looked at how do we support the well-being of our individuals, not just in terms of what we're currently doing, but for the long-term future. And then the pandemic hit, and this made it needed more than ever that we needed to take care of our staff. And we started off with offering on-site counseling for staff so that our 4,500 staff members could access counseling by 2 counselors on site any time of the day. We offered for the staff that were in COVID wards also web access to accessing support and also group therapy. And this allowed us to highlight that we needed something on-site, ongoing, and proactive. And it was a way of addressing our mental health stigma because we were walking to these groups together. And this allowed us to motivate for a wellness program going forward. And as of 2021, I can proudly say that we have a permanent GSH Health and Wellness program, and where we've employed a staff psychologist and myself, and we run a program that has the following objective: to create a hospital that prioritizes well-being and fosters healthy, safe, collaborative, and responsive environments where staff feel that they are heard, seen, and have a sense of belonging. So our main three aims are to reduce stigma of mental health, to promote well-being through creating safe physical, social, and emotional environments, and continue to monitor and evaluate what we're doing and understand the impact. So we're taking an overall approach, and we're not only focusing on the mental health, but occupational well-being, social well-being, emotional, intellectual, physical, environmental, and spiritual. And in 2022, we launched a staff wellness center, and these are some of the activities that we have at the center. So we've continued since 2020 to provide on-site counseling 5 days a week by our employee health and wellness provider. We do awareness-raising events such as anti-bullying workshops, and also we've trained 30 workplace well-being champions that advocate for what well-being support is available for staff and link them to us in terms of how we can best support them and access care. Then we also provide departmental interventions such as stress and trauma management, team cohesion and alignment workshops, conflict management in the workplace, and understanding your value in the team, as well as psychological safety workshops. We're leading both individually and on a group basis critical leadership skills. We retrain managers to lead with empathy and have these difficult conversations with employees and understand what are the 6 areas of workplace design that may be impacting the stress that they're seeing in their colleagues. And then we've also launched a wellness center, and the wellness center has a gym, which you can see it's one of the most popular areas. As a yoga studio, we have fitness classes like boot camp, meditation, massage chairs, self-defense classes, gender-based violence support groups, arts and crafts, and where staff can design their own team building, all for free. So all GSH staff members have access to any of the services for free. We also have trained individuals in the hospital to provide peer support to their colleagues, and we run weekly support groups in terms of coffee chats where people in an open space in a non-threatening environment can come and have a free cup of coffee and chat to a person who's trained with lay counseling skills to support them. And in this way, addressing the stigma of mental health. And we also provide monthly support groups for various colleagues in terms of building relationships and understanding the stress that they're going through as a team. So this is not, we've done this at GSH, but the world has also awakened to this way of working. And the WHO released a paper last year which speaks to these 3 key strategies to looking at mental health in the workplace. And it has 4 main aims, and that is to look at it in a preventative way, to prevent work-related mental health conditions through psychological risk assessments, where it includes organizational interventions to reshape the working conditions, cultures, and relationships, to protect and promote mental health at work through training, interventions, and to improve mental health literacy, strengthen skills to recognize and act on mental health conditions at the work, and empower employees to seek support, to support workers in terms of reasonable accommodations and return to work programs and supported through employment initiatives that the occupational therapists have been doing over the last few years, and then to create enabling environments where we improving mental health at work with actions to improve leadership skills, investment in mental health at work, integration and participation in terms of what is evidence-based and what is in line with the labor laws that my colleague spoke to earlier. And then lastly, I think we can't afford to ignore this, because if we know that by 2030, depression is going to be the single most global burden of disease, then the cost by then will be 16 trillion rand to organizations globally. So with anxiety and depression being the primary contributors to this. So the key approaches that we need to take is not an individual approach, but a systematic approach, and a proactive versus a reactive approach. And I'd like you to leave you with this, that people don't leave bad jobs. They leave toxic environments and uninspiring cultures. Build a workplace where people thrive and retention becomes a natural consequence. Thank you.
Then third and final speaker for tonight. Now I'm going to be introducing Dr. Madri Engelbrecht. She is an occupational therapist at the Stellenbosch University and a research fellow in the Division for Disability and Rehabilitation Studies. Her practice is focused on disability and employment. She applies the supported employment model to facilitate the entry of persons with disabilities into employment, to establish the integration of persons with disabilities in workplaces, and to support both the employer and employee in achieving sustainable work integration and productivity. Her clients are persons with a variety of disabilities, including physical, psychiatric, neurological, and sensory disabilities, and she has worked in public health and the private business sector with small, medium, and large employers. Her research activities include investigations about supported employment and work transitions of persons with disabilities, disability inclusion, and occupational justice. Now to welcome Dr. Engelbrecht. Thank you so much, and over to you.
Thank you, Botumelo. Can you hear me?
Yes, we can hear you.
Okay, good. I just want to share my screen. And you can see my screen as well?
Yes, we can.
Thank you. Good evening, everybody. Thank you for my co-facilitators and panel members for the interesting presentations. My presentation is going to latch on to a lot that was said by Lindsay and Misha to give a little bit more of a practical example of how occupational therapists form part of teams, and specifically employment teams, employer teams, in relation to mental health and keeping people with mental health conditions in employment and in workplaces. So maybe just quickly to mention that while I was preparing this presentation, I had a look at what do we know and what literature we have available and what research is being done about mental health conditions in the workplace, and specifically programs, employer programs that assist people with mental health conditions to be in work and to stay in work. And just to show how, like Misha was saying, it is so pertinent for us to be talking about this, is that we have much less evidence about workplace disability management programs that have a focus on people with mental health conditions, as opposed to people with other types of health conditions, particularly musculoskeletal conditions. The one systematic review that I looked at only 2 out of the 13 programs that was reviewed had a focus on people with mental health conditions. So in the interest of time, I wanted to just start my stopwatch. I'm going to move on to explain 2 specific cases to you where occupational therapists became part of the team in looking after and assisting a person with a mental health condition to stay in work. Sorry, just moving past these. So I wanted to tell you about a medical doctor, Dr. D, who a couple of years ago was diagnosed with cancer, which is a physical condition, but then obviously got booked off from work and had to undergo treatment, which included surgery as well. And a few months later, while she was still off work, her oncologist referred her to a psychiatrist for intervention because she was really struggling emotionally and psychologically with the trauma of the diagnosis, as well as the medications and the treatment. So she started seeing a psychiatrist who diagnosed her with adjustment disorder and differential diagnoses of depression and premenstrual dysphoric disorder. And she was put on medication and treated for another few months while she was out of work. So her symptoms were definitely alleviated by the medication. Her cancer treatment was going well. And between her and her doctor, they decided that she was ready to go back to work. So in July of that year, she returned to work as a doctor in a public health institution, a large public health institution. And I'm mentioning that because I know that you know, or you can imagine what sort of what the job would look like in an environment like that, and the kind of demands on a medical doctor, for example, in a oversubscribed type community level clinic where she was working. So she went back to work in July. And going back to work in this instance literally meant that from the one day to the next, she stepped back into the exact same position and with the exact same job demands, and nothing having been addressed or changed or intervened or anything like that in her work environment or with the job that she was doing or the job tasks or anything like that. So almost immediately, but about 3 or 4 weeks into her return to work, she started presenting with a lot of symptoms and entered a relapse. So the symptoms that she displayed at work were very disconcerting and in some cases bizarre, manifested in bizarre behaviors. She was verbally aggressive towards co-workers, towards patients. She was disruptive. She showed manic behavior. And of course, her work performance deteriorated tremendously. She wasn't following treatment protocols with patients. And it took some time for her employer, in the form of her line manager, to convince her to go back to her doctor. So her doctor saw her and she was immediately booked off again from work and started on new and different and added medication. And then a few months later, she attempted another return to work. At this point, her diagnosis was revised as schizoaffective disorder, which I'm sure that many of you know that it's a psychotic disorder, but with mood elements, and would be classified as quite a serious mental health condition. And then her medication was changed, and she was booked off from work for another few months for recovery. So the year after, her doctor and herself were at the point where they decided that she is about ready to go back to work again. But at this point, an occupational therapist was brought in to do an assessment about her ability to go back to work, which involved, I think Lindsay mentioned, and Misha as well, how this involved an assessment of both the work environment and the job function, the job tasks, the demands, as well as an assessment of Dr. D, her abilities, her presentation of the health condition, and her level of functioning. So that the assessment was done, and she was found to be asymptomatic and to have regained a level of function that would allow her to go back to work. But what was identified, for me, it seems quite obvious, but from the work environment, is that no interventions or any sort of interaction or engagement was ever made between anyone and the workplace. And the things that had happened when Dr. D was ill, and the kind of behavior that she displayed, left staff members, co-workers specifically, with fears, with anger, in some cases, a complete breakdown in trust in terms of her ability to do the job, or just as a trust as a co-worker. So the work relationship had suffered tremendously, and none of this had been addressed or explored in any way. And so the OT made a recommendation that some intervention needs to take place in the workplace, with co-workers, and work preparation need to be done before Dr. D can go back. Part of the work preparation also involved the OT working with and having discussions with the line manager and supervisor of Dr. D about what a return to work would look like, and what sort of reasonable accommodations may need to be in place for her to come back to work. So, and bringing our minds back to reasonable accommodation, which in some instances, especially where physical disability or physical conditions are concerned, could be quite not easy to identify, but concrete, and easy to understand. With mental health conditions, it's sometimes different, and it's not necessarily tangible, but the people thinking about and working out reasonable accommodation have to think sometimes a little bit out of the box. So in the case of Dr. D, what was negotiated at the time as part of reasonable accommodation was allowing her to come back to work in a graded fashion, which meant that she did not go back to work completely full-time, 8 hours or 12 hours a day sometimes, and with a full workload, but that she started with very reduced hours that were very gradually increased, and that the job task, which the occupational therapist had analyzed together with job analysis earlier, that certain tasks get given to her initially, and that those were also graded to more complex tasks and a higher load of tasks. So, for example, in the beginning, when she went back, she didn't do one-on-one patient consultations. And later, when she started doing one-on-one patient consultations, she didn't do it on her own, for example. So some of that reasonable accommodation also most definitely provided the opportunity for her and for her colleagues to monitor and to rebuild, I think, some of the capabilities and trust that was lost previously. So she then started with a graded return in June, and the return was, generally speaking, it was graded very, very gradually, and it was planned for her to actually take her full workload only by the end of that year. But because of operational requirements, like I said, the kind of environment you can imagine, that it's a fairly under-resourced, almost high pressured environment. It wasn't possible for her to only fully return by the end of the year, and she needed to take up her full workload by September. Another reasonable accommodation that was built in, that was negotiated, was the availability and the presence and for the occupational therapist to do on-site support and job coaching with Dr. D during a work day. And initially, those sessions would be very regular, like once a week, and then it started to taper off until the occupational therapist who acted as a job coach was not involved anymore. So I think one of the important things about this case that I wanted to point out is the amount of time that Dr. D was out of the workplace, which was a full year and a half before she started to go back to work. And we know from statistics that the longer someone is out of work due to injury or ill health, the smaller the probability becomes that they will return. So Dr. D, just trying to move to my next slide, Dr. D eventually returned to work against those odds. I think that the element that wasn't there before, previously, when she tried to go back to work twice, is that there wasn't an occupational therapist involved that could direct the process to negotiate reasonable accommodation and implement those in the workplace. The other thing about her case is the employer involvement, which was very strong from the beginning. With the occupational therapist's facilitation, there was a lot of education and sensitization that happened, not just with Dr. D's line manager and supervisor, but with the co-workers during a debrief session initially, and then a psychoeducation session. And I saw the questions beforehand about disclosure, for example, about mental health conditions. So those kind of sessions and those conversations took place only once the OT and Dr. D had conversations about what can be disclosed, or what level of disclosure would be acceptable and appropriate, and as well as confidentiality issues. But it was important to have those conversations with management and with co-workers to explain the reasonable accommodation and also the process that was going to be followed with Dr. D coming back to work. The occupational therapist in this case was a private occupational therapist, which means that Dr. D could pay through her medical aid for interventions by the OT, which is different for most people, a lot of people, in employees who don't necessarily have those means. So in the interest of time, I'm going to move on from this case, and I will tell you about a slightly different case. About Anne, who has been working at a construction company, a large international construction company, for the past 9 years. After she was diagnosed with bipolar affective disorder with very severe anxiety, almost 20 years ago when she was a student in law. And over the past 10 to 15 years, she had been in hospital multiple times and very often extended stays in hospital because of her diagnosis. So at a point when she was not in hospital anymore, but still involved as an outpatient at a psychiatric hospital, and having participated in rehabilitation over the years, an occupational therapist got into contact with her about a vacancy at this construction company. At the time, the OT was involved with the company, the employer, in in helping them appoint more people with disabilities, diversifying their workforce, and assisting them in designing jobs in a way around people with disabilities so that they can come into the company and stay with the company. So at that point, the occupational therapist had done job analysis of various vacancies that were available in the company. And when Anne got into contact with the OT also did an individual assessment with her, with the idea of finding a match, if there's a match between her interest, her abilities, and her experience, and what was available with the company. So a match was found, and at that time, the OT then assisted her with her job application to apply for that specific vacancy. Other people with disabilities were applying for the same and for other vacancies in the company at the time. So the OT was not just assisting Anne, but because of the mandate and the endorsement given by the employer at that time, the OT was available for job seekers with disabilities to come into the company. So even at that stage in the recruitment phase, some reasonable accommodation measures were implemented and available to someone like Anne. So I've mentioned before that she has very, very high, severe anxiety, and any sort of job interview environment would most certainly spike someone's anxiety. In Anne's case, it was in the past, it had always been very quick to spiral from high anxiety into relapse. So with her application and with the preparation for interviews, the occupational therapist coached her in how to prepare herself for the interview, and she identified together with Anne that someone, and in this case it was the OT as the job coach, should be present in the interview situation as a support person, as a silent support person. Anne was then successful in her appointment as the receptionist, and some further discussions and negotiations with the HR department took place around reasonable accommodation measures for Anne to move into the job, so to facilitate her transition into the job, and then to acclimatize and be in the job and then maintain that position, but also to develop further in the job. So I'll come back to that a little just now. On the company side, what the OT also assisted the employer with at that stage, but also earlier when Anne started the application process, is to look at their HR policies about how to bring people with disabilities into the company and how to appoint and support people with disabilities. So there was the information that Lindsay also shared earlier about legislation and employment-related policies and things are definitely of interest for someone working in this space, and especially occupational therapists, and because I'm speaking for that frame of reference as well, and was very helpful in assisting an HR department in designing and redesigning policies that are sensitive to disability and to reasonable accommodation measures. So in Anne's case, some of the things that were done, and I think the most important reasonable accommodation measure that was put in place for her or with her was the continued availability of the OT as a support person in the workplace, and who could offer job coaching and intervention on site in real time at the workplace. And in her case, that was how we constructed it with HR. That's what was that it is part of reasonable accommodation. Another measure that was put in place was, again, the graded exposure to different job tasks, from simple job tasks to more complex job tasks, and from fewer job tasks to more job tasks. It was another reasonable accommodation. And then with Anne in particular, we negotiated a very specific type of sick leave accommodation because of how her symptoms presented at different times, and I can't go into detail about that, but it was definitely something that was different from other employees. But it also meant that she has never in her 9 years of working for the company exhausted her sick leave or has been hospitalized. So her case was slightly different. There was OT and assessment and intervention. In Anne's case, she works for a motivated employer who made a budgetary allocation to occupational therapy, to having a therapist on site and on board who could provide or assist them with reasonable accommodation and provide the support that Anne might need. And they specifically, what they built that budgetary allocation in to their training and development budget, which falls under HR. They most definitely a sensitized employer who had from the very beginning a strong mandate to integrate and employ a more diverse workforce, which was obviously very helpful. And the company benefited and still benefits from not just Anne as an employee with a disability and with a specific type of disability, but other employees with disabilities who work for them in terms of legislation like the BBBEE scorecard and the employment equity targets. So just in conclusion, this has been said throughout the evening, reasonable accommodation is varied and very much individual. Specifically, in our practice, generally speaking, we construct very tailor-made or customized reasonable accommodation measures along with employers and employees. And I think what's important that, again, it's been mentioned throughout, is that the very specific skills that are brought by the OT in the workplace in supporting someone with a mental health condition to be in work and to stay in work is the job analysis skills, the assessment skills in terms of assessing the individual and having the knowledge and understanding about health conditions, and more particularly the impact on functioning, and in this case on work functioning, and then being able to do the job match between what the job needs and what the individual needs and how those two come together, as well as being able to figure out very often, again, with the employee and with the employer, what sort of ways a job can be adapted to allow for reasonable accommodation, but maybe sometimes not even reasonable accommodation, just adaptations in the specific work tasks or in the environment around the person to make that job match more optimal. And then I think one of the things that occupational therapists that underscores all of the skills is counseling, the counseling ability. Thank you. That's all from me.